Hello, Pa. We will continue our IJPP discussion, and now we will discuss developmental screening in office practice, written by Dr. Rima Chandramohan. Okay. So if they are asking developmental screening, first give an introduction. Okay. It is an important part of high-risk newborn follow-up. And you know that first 2 years, the maximum brain growth happens. And the brain's ability to change in response to whatever experiences happens is maximum in the first 24 months. It slowly comes down like this. Okay. Then after that, for the brain to change its way, it takes a lot of time and a lot more experience. Okay. So the ways cannot be changed so easily. Plus, it's during this time, during this first 5-year period, where you have maximum neurons which are developing and they form new connections. Okay. After this particular period, what happens is whatever connections are formed gets pruned so that only what is needed is kept and what is not needed is, removed, pruned away. All right. So before this happens, you need to identify who are the children at risk of having a developmental delay or who are already having a developmental delay and put them on the right path so that it can be intervened at the right time and put them on the best course of action so they will have a better childhood and an adulthood later on. Okay. So that is about your introduction. In identification of a developmental delay, there are 3 things that you need to know. It's a 3-tier system. What are those 3 tiers? First one is developmental monitoring or surveillance. Okay. So this can be done by either the parent, the primary physician, whoever is the caregiver, they can do. They can do it in 2 ways. One, they can compare it with older sibling. My older child was like this, but this child is not doing that. That is one way of doing. Second way of doing is online. There are a lot of questionnaires or checklists that they can follow for the first 5 years. Okay, so they can do that. So this is developmental surveillance monitoring. Second part is developmental screening, which is what we are going to be talking about. So developmental screening, again, it can be done by either parents or physician. And if you find something abnormal, then they will undergo a formal developmental assessment. So surveillance, screening, assessment. This is the 3-tier system. Okay, surveillance, screening can be done by both. Okay, surveillance usually the parents can do or the doctor can do when they come for a well-child visit. Screening ideally to be done for everybody, but the constraints are time. So at least a focused screening should be done to those children who are at high risk, where high risk people are 2. Either parents are having concern that my child is not developing appropriately. Second thing, setting for a high risk, say maybe a very premature baby or failure to thrive child, whom you're obviously seeing is not doing so well. Okay. So this is focus screening. So need for developmental screening, studies have shown that up to 12% have some form of neurodevelopmental disorder. And among these 12%, at least 20% of them have more than one, meaning 2 or more of developmental disorders present. Okay, so it's important to identify them and intervene at the right time. All right. So developmental delay affects 10 to 15% of children. So you need to catch them at the right time, right place, which is usually in your outpatient practice, because that is where they are going to come. And most of them don't come for a developmental problem. They come as a well-child visit or maybe for an upper respiratory tract infection. But if you pick them up, then you're doing them a favor and you're doing everybody a favor, basically. Okay. So ideal screening tool, there is no such thing as a very ideal screening tool because you want something that is rapid. Okay. It should not take up your time. It should have a good sensitivity and a specificity. And you need to have adequate manpower to do that screening for you. You cannot be a one-man army. You cannot say, I am going to see this child for well-baby visit. I'm going to do the developmental screening. I'm also going to give the vaccine. You can't do everything. You need to have somebody and you need to train them. Okay. And the cost effectiveness and cultural sensitivity, linguistic sensitivity also has to be taken into account. You can't go to a village in a particular state and ask them to fill out a questionnaire that is written in English. Many people may not be able to do that. Okay. So these are the characteristics of an ideal screening tool. What are the barriers to doing good developmental screening? As I said, 1, cost, 2, time, 3 manpower. I have all these 3, but I do not know what screening tool to use. Okay, I know what screening tool to use, but I don't know if I can do it effectively. And even if I do, whether I'll be able to manage this child, or I have done the screening. I know how to do the screening well, but I don't know where to refer this child. So these are all the barriers. Okay, so time constraints, lack of adequate subspecialists, lack of consensus, lack of physician confidence in their ability to manage, high staff turnover, or difficulty in training. Okay, so if you remember like this, it is easier for you to do because this goes in a continuous fashion. Okay, so now that you have talked about introduction, you have talked about why you do a developmental screening, the tiers of a developmental screening. You have talked about focused and routine screening. You have talked about ideal screening, and you have talked about barriers. So what is the screening tool that is available to you on hand? There are multiple screening tools. Okay, some 6 or 7 is listed here. We will go through one by one. Very simple. Developmental observation card. Basically, 2, 4, 8, 12 months. These are the milestones the child should have achieved. So this is in a pictorial format. This is in a tabular format. It can be stuck anywhere. Anganwadi worker can do. Parent can do. You can give it to the parent. Tell them, see, Papa, 8 months, your child should be sitting. If the child is not sitting, you come. And the parents themselves will know. They can see that and they can make sure, see, my child is 9 months, but still the child is not sitting. I will go and see the doctor. Okay, so that is development observation card. You see and you observe and you know that it is not happening according to how it is supposed to happen. Then CDC grading for motor milestone, your head control, your sitting, standing. There are different milestones. You guys must have come across this. Correct. So 0 length 5 varaikku there is scoring. 0, 1, 2 is abnormal development. 3, 4, 5 is normal development. Okay, so this will help you to form an opinion about developmental status of the child and refer them at the appropriate time. Then you have Trivandrum Development Screening Chart and Language Evaluation Scale Trivandrum, TDSC, LEST. Okay, so you have 2 charts, 0 to 3 years, 3 to 6 years. So up to 6 years, you can administer this one. How do you do this? You see what is the age of the child, put a scale or a vertical line over the chart, go the previous 3 horizontal lines that you see on the screening chart. Okay, you can see, look at your IJPP books. The charts are given in a very small format and it is available online. You can always go and see it. So the 3 things that are immediately preceding the lines should be achieved by the child. If it is not achieved, then it is a cause for concern and you refer them for further evaluation. So that is about Trivandrum Developmental Screening Chart and Language Evaluation Scale Trivandrum. Language evaluation is just for language. TDSC it looks at almost all domains. Okay. Then good enough draw man test. It can be done, but note that this has to be done above 3 years of age. Why? Because 3 years is when they will start to draw a circle. You need a face for a man, obviously. Correct? So you need to draw a circle. Not you, the child needs to draw a circle. And for that circle, you give them 3 years. Okay. Beyond that, every body part that they draw, you will give them additional 3 months. Okay. Suppose they are drawing some, say, 10 parts. Okay. So a part can be anything. It can be one chest, one hand, one finger, one eye. Example. So if you are having 10 parts, then 10 into 3 will be 30 months. You already have a nice face. So that will be 3 years. So 3 years plus 30 months. How much ever is the max for that, you do. The 30 months and 2.5 years, it will come, I think. So the child will be 5.5 years. Okay. So this is how you do a good enough draw a man test. You can do this mathematics, or if you are very, very poor in mathematics like me, there is a nice table that is given for each score. How much is the approximate age now? So that goes up till 15 years, 9 months. Okay, so you can see the table and nicely say, okay, this child is appropriate for age, not appropriate for age. Okay. Then you have a 10-question screen for childhood disability. See, this 10 question is addressed to the parent or whoever is taking care of the child on a regular basis. Okay, you do that and you can see if this child is at risk for a serious problem. Okay, because this basically asks very direct questions, yes or no questions. Okay, whether the child is able to sit, stand, walk, yes or no. Child is able to see, yes or no. Child is able to hear, yes or no. Child is listening to you, yes or no. Is the child having fits, yes or no. Is the child not speaking at all, yes or no. Okay, so the sensitivity is very good for serious problems, like 80 to 100% you will pick them if something is wrong. But a positive predictive value and all is less. Okay, so around 10 to 15%, not more than that. And this can be administered to 2 to 9 years, not less than 2 years, not more than 9 years. This is where the applicability stands for 10 question screen for childhood disability. Then a little bit better sort of screening tests, nice names, Denver screening test and Bailey developmental skill. Denver developmental screening test, 0 to 6 years you can do. There are tools that you require. Okay, 4 domains that you will read, no? Pigai, gross motor, fine motor, social and language. Same domains like this Denver also will assess. Okay, normal, suspect, untestable will be the 3 responses that you will get. Normal naka, all administered items a child has cleared. Suspect naka, there is 2 or more caution or delay. There's a table here that you can go through. Okay. Or untestable, na child is refusing to cooperate, or the child has not had an opportunity to even learn what you are talking about. Then you can't tell the child to hop and skip if the child does not know how to skip. Correct? Because child has not been introduced to skipping. Right? So that will become an untestable situation. Bailey, it can be given from 16 days till 42 months. This also examines in all domains. This also requires a kit. Okay, so whatever we talked about so far is basically physician administered, except maybe for the 10 question screen where the parent or the caregiver has to give. There are certain screens which are parent completed screens. We will talk about 3 of them. Okay, one is ages and stages questionnaire. You just pick up the questionnaire according to the age of the child, give to the parent, ask them to fill, and they will fill and give you. Then you see whether it is score, and after the scoring is done, you compare it against a chart. If it is appropriate, then you tell it is appropriate. If it is not appropriate, then depending upon how good or bad your assessment is, you ask them to come back for follow-up or send them for a formal assessment. Next one is parents' evaluation of developmental status, developmental milestones, PEDS DM. Nice to remember for people who want to do DM. Okay, super specialty. So this can be administered from birth till 8 years. The previous ages and stages is still 5 years. The PEDS DM is still 8 years of age. Okay. So here also age-wise, you are having 6 to 8 items per visit, and each item will test one particular domain, say language, receptive language, expressive language, gross, fine motor. Older child, they will look at max and reading. So each domain you will see with one item. If they are not passing that item, then they are below the 16th percentile for that particular activity in a chart. Then you raise concern to the parent and ask them for further assessment. So this is about PHDM. Next, screening for autism using MChat. The MChat is modified checklist for autism in toddlers revised. See, this MChat, remember, it has to be administered at 18 months to 24 months. Okay, 1.5 years to 2 years, you should do an assessment. Whether they are coming for vaccination, that they are coming for a simple infection, do a simple MChat. You give to the parents, it's them who are going to do. You see what is the response and then you assess. For most items, yes is the correct answer, except for 2, 5, and 12, where no is the correct answer for that 1.5 to 2 years of age. Okay. You see what are the at-risk responses that they are having. If the at-risk response is 0 to 2, then this child is not at risk of autism. You're okay. This 3 to 7 is the gray area. That is the moderate risk area where you need to make a call whether to ask them to come back for follow-up or you send them ahead for an early intervention. Above 8, there is no question. You send them for an intervention. It has 20 questions. It takes hardly 10 minutes for them to answer that. It is whether the child is moving a finger right in front of their eye. Do they like, you bouncing them up and down? Those sort of questions, yes or no, pretty straightforward responses. Most parents will be able to do. Okay, so these are all parent administered. We already saw the criteria for good screening tool. We will not go ahead and see that again. Screening tool ideally should be simple, culturally appropriate. Okay, R is for another rapid. I also forgot. Okay, so simple, culturally appropriate, rapid, effective, easy on the purse. N is for nil or minimal training. Okay, so this should be an ideal screening tool. And if you have parental concerns, then ask them to come back for an early visit, even if your screening is normal. Don't ever discount a parent's concern that the child is not developing appropriately. Ask them to come back for a follow-up, reassess. If they are still concerned, send for a formal developmental assessment to a developmental pediatrician. Okay, so I think this should be enough. So if they ask about developmental screening, you will give a small introduction. You will say why you are doing a developmental screening, the epidemiology part of it. Then you will tell what constitutes an ideal screening tool. You can remember the screen mnemonic. Then you will talk about what are the barriers to doing a screening. Then the doctor administered screening, you will talk about 6 or 7. You will talk about parent administered screening, which is 3. And then you will end with a nice thank you note. Okay. Bye-bye.